2009, Tom Finney, who's in the audience, one of his first tasks in PHE probably was to do a lit review of enclosed institutions and the outbreaks that we saw. So we knew that enclosed institutions have higher attack rates and worse attack rates than would be expected kind of completely at random. Then we saw the Diamond Princess and other cruise ships early on in the pandemic, and the potential size of those outbreaks. And then Lorenzo Pellis was asked by Graham Medley on SPI-M to look at the impact of shielding care homes. And so that was in February, late February, early March, and we sort of did that and went through that discussion at SPI-M. And then we started seeing outbreaks through March as the surveillance started to come in. And this is the number of outbreaks. Hopefully if I press it, good, it's a pointer. So these number of outbreaks being reported to health protection teams. So we started looking at this kind of after a couple of weeks of data. So we were seeing exponential growth. And then we saw the leveling off, and this is a little bit cringeworthy now. We've published it, and we probably, looking back with hindsight, we might do things differently. But this gave a strong trigger to PHE, as was, to go in and do some concrete epidemiological studies. So they were able to go in and create what they called the Easter 6 program, to look at those outbreaks and do genomic analysis and look at outbreaks and what caused those outbreaks, and the fact those outbreaks are caused by multiple introductions, not a single point of infection and things like that. So it gives us the complexity of those outbreaks. Then we also looked at running the models here are just Gaussian additive, Gaussian process splines in a generalized additive model. But we also looked at the spatial effects, and we were able to see the Northwest, Manchester and Liverpool, but also Oxford and London had sort of a worse setting, higher incidence of outbreaks. And we're able to start to see that was because in some urban areas, you have lots of small care homes that share staff. In that period, they were sharing staff. Or you have regional groups. So it's not like Bupa, which would be a massive national chain. You'd have regional chains that may share staff. And so we're able to create a hypothesis that staff were some sort of, I'm trying not to use the word vector, but for the purpose of this audience, we'll use vector. But that's probably an emotive term that I wouldn't necessarily use in other audiences. So what happened then? We were looking at this, and Graham Medley sort of said to me, well, can you try and coordinate some of the SPI-M work? So we brought in Alicia from London School, Leon from Exeter then, now Bristol, and we created a sort of social care subgroup of SPI-M, which lasted about a week or two before before Sage adopted us, and Charlotte, who spoke earlier, came and co-chaired with me this group. And we were set up as a task and finish group. So the other task and finish groups, not necessarily an exhaustive list, are there. And then you have the big four that Charlotte's already mentioned. The beauty of these, and I did write these slides before Charlotte spoke, I stress, and I have witnesses here. The beauty of the social care working group, as was care home working group, as was the multidisciplinary nature. And we had geriatricians, which is a term I'm not supposed to use, but it's a good explanation, I think. So yeah, experts in the care of the elderly, virologists, epidemiologists, modelers. Just because there was a modeler chairing or the academic chair in the SAGE language doesn't mean to say that it was all about the modeling. There was a lot of other expertise that was needed here. And we created a lot. I don't know why that first one was a hyperlink, but anyway, we created a lot, and this is not exhaustive. These first few are the big ticket SAGE papers that landed from the working group. I know sort of Charlotte, I don't think she quite said, it was set up as a task and finish group. We only finished in April 2022, so we actually went for 2 years. So it's quite a long task that we were on, and that's probably a lesson to learn as well. But yeah, we went through a series of policies. I will talk to some detail about these, but each of these is probably a talk in its own right. And then we have the more sort of traditional outputs for academics, I guess, where we were looking at case fatality rate, other settings. So Joe, who's got a poster, we did some work with him on refugee camps, and then looking at excess mortality, EpiBeds, which was one of our models where we embedded people in Manchester Foundation Trust to understand what was going on in hospitals. I think my original talk title was nosocomial transmission, so I do worry we're all expecting lots of hospital talk. But I think we did embed people in the hospital to access data and help their planning, which was quite important. And then we go into the sort of wider reports, and it's almost impossible to count the number of SPI-M papers or social care working group papers or environmental modelling group papers that we contribute to that don't necessarily get published at a SAGE level in the public domain. And I think how we publish that came up as a question I appreciate earlier about how we publish that and translate that to the wider society, of general public leadership. I'll just go into some vignettes really just to sort of show what we were doing. One of the questions we had was forecasting. So how bad is it going to get? Now, we weren't going to recreate SPI-M and medium-term projections because that already existed and we were already contributing to that. So I kind of just drew a line at short-term forecasting using the generalized additive modeling approach that we'd used early in the pandemic to look at the doubling time, 3-day doubling time assessment with Lorenzo and Thomas House in Manchester. But we extended that. So this is the time series of deaths. We fit a generalized additive model with a spline over time with a weekend effect. So Anne very helpfully talked about that. And then we can extract from that the growth rate very easily. And then I have a PhD student who's working on turning that into an reproduction number estimate. So, Anne, I'll probably talk to you at some point very soon about that. And this went into the PHE or UKHSA joint modelling team report each week or period, just forecasting how many deaths they might have in the next fortnight. And it's useful because you can start with the growth rate. And I'm sort of, I don't want to recreate Anne's very, very well argued. I think one of the things is we can just answer the question, is it growing or is it decaying with this, and give some uncertainty on that, which was useful for people when risk assessing, I guess. Then severity, we can look at the time series of cases, as in tested positive, and the mortality to come up with the case fatality risk over time. And this is a useful diagnostic to look at impact of intervention. So we can see here that testing was a basket case as a technical term in the first wave, where they were testing symptomatics only. So the case fatality rate is largely meaningless here. And then it drops, it seems to be getting better. That's because of the recapturing of people by PCR after they've been infected in wave 1. So that's sort of an artifact of the testing being ramped up. And then it stabilizes pre-vaccine at sort of 20%, maybe 25%. That's for people who are over 70 in care homes. So that's the case fatality rate that we were looking at then. Then you have the vaccine effect where it drops by about 0.5 to 13%. Throughout sort of Delta and Omicron. Too many things are changing here to say this is, we can say that's because of vaccine empirically, because vaccine happened just before it, but other variants are coming and going. We can see that it's halved again to about 5 or 6% with Omicron coming through, and we're continuing to sort of monitor that. But this was really helpful for UXA colleagues to understand severity, and I think this work was really quite useful, and it's effectively in real time as well. And another question we had was on vaccination. So JCVI said that they could vaccinate the elderly. That meant they had to deploy the vaccine to care homes. And so they turned to us and said, what's a good target? And we all cringed and went, please don't aim for this as a target. And so I did some work. I got Keeling and Rahani out and looked at 2 risk group modeling and came up with for different assumptions on effectiveness or efficacy, what sort of coverage we would be needing. And so we came up with these 80 and 90% values as thresholds for controlling an outbreak should it be introduced. This then goes through the policy cycle. This went through policy teams in DHSE, and it comes back to us that they were monitoring the vaccine targets, and they easily got the 90% in residents because the residents are kind of wanting to be vaccinated because they can see the benefit. Staff vaccination was lagging behind at 50 or 60% for quite some time. And so policy teams went away and said, well, the only way we can boost that is by mandating vaccination. And so yeah, sometimes though, I think there was a question before about sort of the interaction between policy teams. And sometimes the policy teams go away and come up with a policy almost out of the blue that we wouldn't necessarily dream up as modelers. So there is that iterative feedback that's really important here. And we do have to have that continuous dialogue, I think. And then autumn 2020, we were asked to look at visitor policies because visitors were barred from care homes, but there's a well-being issue here, a wider impact here that's not just about the infection risk. And so there's a trade-off. Do we allow visitors with their increase in ingress, or do we and have the impact on well-being and mental health, or do we keep them barred? And so we worked with a health economist, Alex Thompson in Manchester, who worked up a framework. I started off with a cost-benefit analysis. He took that away and sort of turned that into a harm-harm balance. He managed to find some data. It's not all about QALYs. In infectious diseases, we talk about QALYs a lot. It's our usual go-to kind of framework. But when you're talking about well-being and frailty, it's a little bit harder to come up with that balance. And so we were left in a little bit of an awkward situation, but actually we were able to see that the well-being benefits were almost an order of magnitude higher than the disease risks. So it was okay. We didn't have an awkward conversation about balancing harms, but in another situation we might have been. So there needs to be more work integrating infections with well-being and looking at those wider impacts. I'll sort of speed up a little bit here, but another key question we had was on testing. And I sort of spoke about this at a previous I&I meeting, so I won't go into too much detail on the testing work we did. But we were looking at the in-host dynamics, piecewise log linear, kind of in-host dynamics, and feeding that into testing models and how much you can reduce infection potential by different testing regimes, ad nauseum testing regimes almost. And the key thing, and I can't stress this enough, is thinking about adherence. And so we can't just assume everyone behaves as we hope they would behave, but we needed to find data on adherence. But it's not just data on adherence. It's our structural assumptions about what we mean by adherence. And so we could make the simple assumption that it's just tossing a coin, a weighted coin, on adherence. And so, yeah, it's random. People just arbitrarily kind of do it or not. Or there's some sort of structural stubbornness about testing. Some people don't want to test. Some people always are willing to test and won't forget. And so these are the two extremes. Clearly, it's a continuum. Clearly, some people forget and some people are just a little bit stubborn. But at least looking at the extremes, we can start to tease that out and just avoid making a structural assumption in the modelling. And we've extended this under the PROTECT project, National Core Study on Transmission, to sort of develop our in-host modelling. Tom's talking on this, talking on in-host modelling in a slightly more detail tomorrow, so I won't belabor this, but I can talk at length about this as well, especially also then dose response. And dose response is another area that I could talk at length about what this means when people get an exposure. But coming back to vulnerable settings, one thing about a year ago, or a little bit more than a year ago, we were said, okay, we've got vaccination now, so surely the problem's solved. Can we just, what mitigations do we have in a post-vaccine landscape? And we were a bit queasy about this as participants on the working group, and we tried to break that down a little bit to understand what they meant by the question. And the day is possibly a little bit ambiguous here, but it's about hazards and it's about profiling that hazard. And so this is almost universal, but you have some ingress risk to the setting. There's a transmission hazard between two individuals or the individuals there. There's then the outbreak hazard, how that maps through to the final size in some sense. And then what is the vulnerability of the population? This gives us a justification for why we might want social care staff to have more regular testing than healthcare workers, because there's this outbreak hazard potential. Care homes could be up to size 100. Hospitals are big, but they're a bit more compartmentalized, and possibly their infection controls a little bit more managed. This also has been translated by UXA colleagues to prison settings and HMPPS colleagues to prison settings as well. So where the vulnerability is slightly different, but people in prison are on average, 10 years older than their biological age. So it's still, they're still a vulnerable population. And this also helps to explain some of the complexity of the intervention space here. We can oversimplify as modelers what an intervention is. The interventions come in and they try and mitigate some of these hazards. The only one that does all of them is vaccination. And you can argue about whether vaccination actually does control transmission or other aspects, but it arguably does. But other ones are unique to a particular point. And so we need to think about why we're putting that intervention in place and what the impact of that might be. Well, early on, we could be testing everyone in the care home setting, but the care home residents are vulnerable, they're elderly, they're confused, they don't really know why they're being tested. So is it ethical just to swab them every day for the sake of it, when actually it's the staff that are the bridging to the community? And so by testing staff, you're getting most of the bang for the buck in the testing. And there were natural experiments there because Scotland didn't implement resident testing, but England did, and there was not that much different in the outbreaks that were seen. And there's obviously cost to some of these if we're paying people to not share transport or things like that. And then we can then look at the transmission potential. So what's happened to transmission over time by looking at the size of outbreaks. And we need to do a little bit more work here, possibly, or I need to write up the work that we have done because this has gone into SPI-M papers already. But we can look at outbreaks, we can look at the average number. You can see that at different points, there's been different transmission potentials. And you can see sort of Omicron coming in, there was a bit of a spike, and I haven't updated this recently. I just realized it's an old image, but we need to be careful and monitor that. And correlation with the community. The community is, these are not insulated settings. They have that connectivity through staff, visitors, and hospital discharges possibly. And so what's the ONS saying? So the black line here is the ONS, and the other lines are different, quite different types of person in the care home. And you can see that pre-vaccination staff and others were sort of twice the prevalent. This is a log scale, so it's about twice the prevalence positivity of ONS. After vaccination, it's about half. With Omicron, it went back to parity. So there's this interaction over space that we need to think about, which could be important, And we hope to look at that with the ONS, but yeah, funding is, I won't go into the issues we've had of trying to get this funded. But again, I can talk at length about my bitterness. And then just to finish off with this, I mean, it's not all about refugee camps, care homes or prisons. We've also done some looking at vulnerability of the logistics sector. This is a collaboration with occupational health colleagues in Manchester. And looking at, so we've developed a simulation model for the delivery sector and looked at various mitigations there. And engaged with the companies to sort of try and look at some of these things. So yeah, this was a potential important actor to reduce contacts by stopping people having to go to the shops, say. So yeah, we sort of worked through that as what part of the emergency funding. So originally, back in the early days when Charlotte and I were looking at the care homes, data was terrible. I think it's very weak is probably a more diplomatic way of saying that. It's improved drastically. We're quite, it's better now. If my colleagues on Social Care Working Group were here, so particularly Bruce Guthrie from Edinburgh, he would say we need social care episode statistics like we have hospital episode statistics. We don't even know who's really in care homes. We certainly don't know who works in care homes. So better data there. Open Safely and other initiatives get at that in part, but it's not necessarily still perfect. We have very fast turnaround. So sometimes simple analysis is all we have. The vaccine work, where I said the 1890 value, that was very, as I said, that was kind of undergraduate level maths. But if we backed that up in the SPI-M papers with stochastic simulations, 2 or 3 different modeling setups, and found slightly lower thresholds, so it was a risk-averse threshold. So we stuck with it even when the more complex simulations came through. Future working. This is my last slide, Valerie. So I won't, and I'm conscious I'm keeping everyone from drinks possibly, so I won't be popular if I keep waffling on. But we had a workshop on the 10th of June with UXA colleagues and Ministry of Justice colleagues. And we realized there were kind of 3 modeling work packages, or sort of hazard characterization, contingency planning, and statistical modeling. But the feedback we got from the stakeholder groups was really about translation of our methods so that they have tools themselves, but also communication. I mean, it's obvious we can't just talk about eigenvectors and expect people to not walk out the room. But there's other sort of some of the other terms we use. We just need to make sure we can communicate. And also it's about visualization. Visualization is important, but we need to add value to that visualization with the inferences that we're making. So just plotting the data doesn't necessarily add to the decision making. And this is all iterative. And I will end there, but yeah, it's quite a long cast list. I hate cast lists because I always forget someone, so it's not deliberate if I've forgotten anyone. But yeah, yeah, I'll stop there in the interest of time.
So if we've got those who've been speaking this afternoon, you can all think about either things from